So the case is a midwife who, I have several videos about it on the second channel, but if you want to go like get caught up, you can. But in general, like overview, it's a person who had had a previous cesarean delivery and had distrust of hospitals and wanted to have a home birth and was pregnant with a breech baby. VBAC should not be a home midwife delivery. Breech should not be a home midwife delivery. Neither of those things on their own should happen at home with a midwife. Those things put together absolutely shouldn't happen on their own, period, at home. And then when you add in the footling breech, that's even worse. Okay, so that's what happened. And then the baby died. And the case is brought by the state against the midwife. The parents did not choose to do that.
Sir, how are you employed? Or I'm sorry, state your name and spell your last name for the record.
Matt, given name Matthew, go by Matt. Last name's Carroll, Carroll.
How are you employed?
With the Omaha Fire Department.
How long have you been with the Omaha Fire Department?
It'll be 19 years in January.
What is your title with the fire department?
I'm a firefighter paramedic.
What does it mean to be a firefighter paramedic?
All firefighters are what they call certified EMTBs, which the B stands for basic, and then probably somewhere in the neighborhood of 40 to 50% of the job are paramedics. And paramedics go through more school, so they can do a lot more interactions than what a EMT basic can do.
Okay, I do want to talk about that training a little bit. So fair to say 19 years ago or so, you went through your initial training to become a firefighter?
Correct.
What basically did you have to do what did that training entail?
I cannot remember for sure how long we were in what they call the training academy. It was somewhere between 3 and 4 months, and that just depends on how short they are. Sometimes it's shorter than that as far as your academy training. And then once you get done with the academy training, and they teach you all the aspects of being a firefighter, both EMS-wise and firefighting-wise. And I'm
going to interrupt you there. EMS is what?
Emergency Medical Services.
All right, go ahead.
And then once you're done with the academy, you go out into what they call suppression. So that's when you're at the stations.
This is still too slow for me,
And
honestly, but
up
if
until
y'all are
you've
not
been on
opposed, I'm
officially
going
for
to keep
1
it at
year,
1.5.
you're considered what
If
they
it gets
call
too
either a
fast,
probationary
just
firefighter
let
or
me know and I'll put it
candidate.
back down.
And once you're done with that, then you're quote-unquote officially a firefighter.
Okay. Is it fair to say that then throughout your career you continue to have ongoing training to maintain
Correct.
your licensure?
Yes.
And make sure you finish my sentence before you talk.
Oh,
because
sorry.
she's taking down everything, and I'm bad at that too, so we can't talk over the top of each other. So somewhere along the line then, I presume you then started working on the paramedic training, is that right?
Correct.
When did you do that?
After I finished my candidate year officially.
Okay. So how long have you been a paramedic?
Oh, I'll turn the speech down. It's fine. I mean, y'all still go if you need to go, no problem. But I'll turn it down because there's no reason we have to have it high except for just my own problem with normal speed.
Right around 16 and a half, 17 years.
Okay. So what was the paramedic training like?
We'll do happy
At
medium.
the time, Omaha Fire did their own paramedic training, and so it was taught by Omaha Fire personnel. So we had to go twice a week, 8 hours a day for roughly a year, and it was both classroom training and hands-on training.
Does someone oversee all of the paramedics? Is there some kind of medical director or something to oversee all of the paramedics at the Omaha Fire Department?
Correct, yes.
And who is Omaha medical, or the medical director? Is that a doctor?
Correct.
Okay. So do you answer to a doctor, or how does that work?
Ultimately, because of what we do out in the field, we actually are all underneath his license, if that makes sense.
Okay, all right, fair. I want to talk directly about what matters in this case. So I'm wondering about actual OB training, delivering babies, experiences, and things like that. So what do you recall being the training you received through the years, both in the beginning and through the years as it relates to delivering babies?
When we were in paramedic class, and it may have changed since then, but we had to do 16 hours. It was 2 8-hour stints in a labor delivery situation. And so the first 8 hours that I did for that as part of the paramedic certification, I saw 2 deliveries, and we're literally there on an observation basis. And unfortunately, the second 8 hours I did, there were no patients that came in, so I didn't see anything.
Yeah, it's always really variable like that, what their training is as far as deliveries. They observe for a particular time frame, and how busy your unit is what determines if they see one delivery, no deliveries, a bunch of deliveries. I think they have to see one, but
Time. Well, did you get training specific to breech deliveries?
The biggest thing they told us about breech deliveries is do whatever you can to keep the pressure off the cord.
Okay.
And then it kind of depends on what the breech presentation is as well.
Okay. What do you mean by that?
There's multiple breech presentations, and depending on the presentation, if the head has not been delivered, then we do what they call a V technique, and it's to try to keep the pressure off the child's nose and mouth.
Okay. So I gather you try to figure out, well, you know which way the child's facing, so you try to make some room so
Correct.
the child can maybe start taking breaths. Okay. So that sort of contemplates that the baby's born up to at least the neck or somewhere along the head. Is that fair to say?
Yes.
Okay. So are you given techniques when you arrive and say there's a foot delivered or 2 feet or something like that? Are there things you're taught to do?
Get to the hospital as fast as we can.
Okay. Is that first and foremost?
Correct.
All right. Fair. Have you ever had to, at your time as a paramedic, firefighter, paramedic, have you had to deliver a baby?
I have not.
Okay. Have you been on scene where a baby has been recently delivered?
Yes.
How often has that happened?
Get to the hospital as fast as you can was definitely the right answer in that. Hype train, thank you, Weekend Cave, for the gifted sub. If you are not subscribed and you want to be for ad-free viewing, you can subscribe using Twitch Prime by linking your Amazon Prime account, or you can hopefully get gifted a sub if you get super lucky, or we try not to talk about important things during the ads.
Twice.
Okay. Was it a pretty normal delivery, other than, for whatever reason, ambulance is being called?
I'm assuming so, yes, because, again, both instances that I've been on something like that, the child had already been fully delivered.
Okay. Have you ever had to clamp off the umbilical cord and cut
Yes.
the cord? Okay. So the examples you're giving, you got there pretty quickly after the baby was born?
Yes.
Okay. All right. I want to talk a little bit about episiotomies. Do you know generally what an episiotomy is? Is that yes?
Yes. Sorry.
That's right. What do you think an episiotomy is?
I don't know the specifics, but it is something where, and I'm assuming it'd be, well, it could probably be a normal delivery as well, but for whatever reason, the child is not coming out, so they have to make an incision to make the opening large enough for the child to be delivered.
You sound like you don't know exactly what it is, so does that imply that you aren't trained on episiotomies?
No, that's beyond our scope of practice.
Would there ever...
Do you all know what an episiotomy is? Should we quickly just learn something? Mostly because I need an excuse to use the new toy. Okay. Let's see. How was I? I did this and then we turned off this one and we turned on this one. All right, so episiotomy in like general terms is basically if you are pushing a baby out and there is not enough room for whatever reason, the indications for doing an episiotomy vary, and we can go over some of those. You would usually use curved Mayo scissors or episiotomy scissors to make an incision. The way that this essentially looks is if you imagine like, let's see, typically this is done when the baby's fairly close to delivering. So if you pretend this is the baby's head and you get a different color for okay, baby's head's going to be blue. Okay, baby's head's right there, kind of crowning. So you would have like the vulva looking like this. The urethra is here, usually fairly compressed. Clitoris, clitoral hood here. Typically fairly stretched here, and then rectum there, anus there. Does that make sense? So blue is the baby's head, crowning, and an episiotomy would be where you would take your instrument and you either make an incision here to allow for more space for the head to exit, or for a beautiful picture, sure. More space for head to exit, or to put an instrument in like forceps or something like that. Or that one's called a medial episiotomy. And then you can also have medial lateral going to the side. And generally when you do that, you're going to, let's see, I would put my fingers like this between, gosh, I don't know how to demonstrate this. So if the head is, okay, baby's head is coming out this way. Pretend that's a whole circle. I don't have a circle here. Look, we'll use my bracelet. Can't see any of this. It's inside. Okay. This would be a medial episiotomy. See how there's a disruption now of the vaginal wall? And to cut it, I would put my fingers here between the perineum and the baby's head, like that, and then use the scissors to cut this way so that you don't cut the baby. That makes sense? So let's see. Lots of people discuss pooping in birth. Is it possible to pee during birth? Yes, sometimes that happens as well. Would you do an episiotomy for a faster delivery in an emergency? Sometimes, yes, that would be something that could be a reason to do that. Is it better than natural tearing? No, we used to think, not we, but like older generations used to think that it was more beneficial to do an episiotomy rather than tear because it's a clean cut and then easier to repair and heal. But really, we've found that that's not the case. So episiotomy to prevent tearing or for better healing is not really an indication anymore. And then, so someone said, I have a friend who said they cut an episiotomy so that they didn't tear it towards the clitoris. This is a hard thing to study, right? But I have absolutely 100% been in deliveries where I was like, if this happens, because sometimes you can kind of just see it coming, like this is going to be really bad. And there probably isn't data to support that. But personally, I would say on an individual one-to-one basis, and I can probably count on one hand the number of episiotomies I cut per year, but there are situations where I'm like, I really think if we don't do this, that you might end up with a tear that's worse if we don't. And it's totally up to you. And I could be wrong, but so yes, there are reasons why that's the case. Why upwards and not downwards? So you wouldn't want to cut upwards because right here, that's the urethra. So where your pee comes out, and that's the clitoris. So you'd be immediately into something that you don't want to cut. The bladder, if you went past the baby's head to the inside and like right here, so this is inside the vagina, right? So if you went around the top of the baby's head into the vagina and then like pressed up, that's the bladder. So you could easily cut into the bladder, urethra, and clitoris in one small cut if you did that. Forceps can be dangerous. I explain forceps like a scalpel. Scalpel could be a weapon, but it also can be an incredibly important tool for taking care of people. So forceps are the same. If you know what you're doing and you do it safely and you're well trained to use them, then forceps can be a life-saving tool. Yes, it is not uncommon to hear about doctors doing episiotomies without saying, explaining, or asking, and I think that is not okay. Thank you, Savory Carolyn. Happy to have you here. Why not on the side? Seems like, yeah, so you can't go you can't go this way on an episiotomy. Like, you couldn't really make a cut here because there's really not anywhere to go. Like, you're going to be cutting through the labia. It's just not going to give you the room. You have bony structures closer there. It's not going to do the job that an episiotomy is meant to do. Yeah, so someone said medial-lateral versus medial, and is it because you might have that tear into what we call a 3rd or 4th degree tear, where it goes through the rectum or anal opening or the sphincter muscle? It is debatable which is superior and if it is more likely or not to do that. And we'll go to our favorite resource here to take a look. So, medial lateral versus midline. So World Health Organization recommends medial lateral as it won't increase the risk of an anal sphincter injury. That's also what the Royal College advises. And ACOG apparently says that it may be preferable. Median is at higher risk of sphincter injury, but medial lateral is associated with increased blood loss. In addition, it might result in more painful healing, but the data is conflicting. Yeah, so when I was training, they were still kind of in a like, oh, we don't really know what to recommend for medial lateral versus median. But current thought is medial lateral. And hang on a second, how do I get this back to where I wanted it? But I would say this is a pendulum that swings and people go back and forth between what they think is better. I thought you needed consent from all conscious patients before doing a procedure that, yeah, I mean, you do. Sometimes it's included in like the paperwork on admission and people, I don't know, but yeah, I wasn't explicitly, honestly, taught to ask for express consent for that. I definitely do. I feel like there is always time, even in a pants on fire emergency, to ask, but I don't know if you can get up to date without being in the medical field, but it is aimed at people who understand studies and things like that, like who've been trained in statistics and studies and reading scientific literature. And I think it's really expensive if you pay for it outright. Like, I have access to it through institutions. It is absolutely crazy how much autonomy is removed from people who are having a baby, and it is alarming in the United States, in my opinion. I don't know how many times I've ever cut an episiotomy, but several. Most of my patients would already have an epidural, or I would put numbing medicine first. I don't think I've ever cut an episiotomy in someone who was not anesthetized, unless I can maybe remember one time where there was a true pants on fire emergency. Someone came in like preterm, baby was stuck. I couldn't do anything. And I said to them, like, I don't have anesthetic right here. I can send someone to get some. They're going to get some. Or we can cut an episiotomy and try to get baby out right now. And I don't even remember what they said, but I would never do that ever without talking to someone about it. And I certainly wouldn't do it without anesthetic, without talking to them about it. Yeah, it's crazy that I wasn't told to ask. Become a doctor so I can have up to date. Perfect financial plan. Yeah. The 6 figures you spend getting your degree would pay for your subscription for a while. Yeah, absolutely. It's not just that. I agree. It's definitely not just that. And it is inexcusable. It's crazy. And it's worse in the United States. Nixie Pixie. I've seen this talked about a lot, and I am certain that this happens where people are doing exams on unconscious patients who don't know. But I do think that oftentimes when I read about it in the media, it's presented as though it's like a patient goes in for wisdom tooth removal and they're asleep, and then people are doing pelvic exams. And that wasn't my experience at all. And I don't think I went to a place for training or schooling that was particularly good about like making sure that we were respecting autonomy. My experience with learning pelvic exams and teaching them to medical students was that the only time a pelvic exam was ever done on a patient who was unconscious was when we were already planning, like the last step before I do most gynecologic surgeries is to do an exam under anesthesia once someone's asleep. If somebody's having a hysterectomy or a DNC or something like that, I usually need to feel of the position of their uterus and all of their important parts before I start putting instruments in there. And that would be, if there was a medical student with me, I would teach them when I was doing my exam already. Sometimes I feel like in the news, it's presented as though we're lining up medical students in the hallway and everybody's going to do a pelvic exam. And while I don't know if that's happened other places, I've never seen that. And, you know, I'm pretty upfront with you guys. I just told you that I was never taught to like expressly discuss certain aspects of obstetric care before I did them. And I would tell you if I had ever seen something like that, but that's not at all what it was. Here in Aotearoa, I really like that we have it expressly on our consent form. So when I'm consenting a patient for surgery, there's actually a section on the consent form that says sensitive exams. And if I'm doing a laparoscopy and we won't be doing a pelvic exam, then we just click or check not applicable. But if we are doing a hysterectomy, I'll say, you know, the last step before I do your surgery is for me to do a exam to feel of the uterus and identify where things are. This can be really helpful for teaching, you know, our students how to do this so that they can take better care of people when they have, you know, they're working in the emergency room and a patient comes in who we need to do an exam like that. Would it be okay with you if while I am doing my exam, I also teach them and let them learn from you? And I would clarify, we're not going to be lining up every medical student outside. This would only be if you've already given permission for a student to be with me that day of surgery, and it would be the student working with me that day. Yeah, for sure. I mean, it should be a consent form question. It's more helpful cat under anesthesia because one, the patient is not uncomfortable, they're not hurting, and I can do a pretty pain-free speculum exam or pelvic exam for 90% of my patients, but when you're learning, that's not the case. And then the other reason is because the medical students are nervous. It is really nerve-wracking to learn to do those exams. You don't want to hurt people. It's sensitive. Most patients don't really like it. But 100%, this is something that should be done with consent. I just want to clarify, and I think I'm all in favor of making sure that that's expressly put on consent forms, but I just want to make sure that my personal experience with this is out there, which was that we would teach that when a patient was already having that exam and had given permission for students to be there and learning from them. And it wasn't lining up a bunch of people to come in and do a speculum or pelvic exam on somebody who was having an unrelated surgery. Even if it was a GYN surgery and we weren't going to do a pelvic exam, we wouldn't do it. I don't know that it would always work like that at every hospital, but that was my experience. Have you ever had a patient want to see what's going on? For birth, for sure, having a mirror actually is associated with patients pushing better because they can see what's effective, especially if they have an anesthetic on board. I've never had anybody ask to do that for like a pelvic exam with a speculum, but if they wanted to see, I'd be more than happy. Actually, At Your Cervix is a production that's coming out soon, and I think it might talk about exactly what we're talking about right now. Yeah. Documentary about consent. And they've reached out to me to ask to help promote it. I'm not promoting it for them, like they're not paying me or anything. But they asked me to talk about it, and I'm waiting on them to get back to me of what they want me to do. But they sent me this, and I love it so much. They sent me this lunchbox. Well, I wanted to show you pictures, not, I guess I could go get it, but it's this lunchbox here, and it says, "With my speculum, I am strong, I can fight." And it has a speculum inside it, and like teaches you how to do a speculum exam and look at your own cervix, which I thought was very interesting. So anyway, I'll be talking about that at some point again as well. All right, did we learn everything we needed to about episiotomy? I'm looking here at median versus medial lateral, and I was thinking, like, I was taught to do median, and it says median is typically performed more commonly in the United States. And the data is a bit mixed, but I think in just reading this, and I do both in practice, I kind of assess the patient individually and try to choose what I think would be best for them. But in reading this, it sounds like it's questionable if there's like real strong evidence one way or the other. But if there was convincing evidence, it would be towards a median midline. Not a subject most Twitch streams would cover. Yeah, well, probably not a subject most Twitch streams in general would cover. Once I had a fellow and resident doing my sedation, and my cousin was a resident, so my sedated ass told the resident. I was so proud of her. That's adorable. I am so glad that you were here too. Okay, why don't we get back to what we're doing?
Would be a circumstance that you would attempt an episiotomy out in the field?
The only way we could do that is if we contacted medical control and they gave us permission.
All right. Let's talk about that a little bit. You've got a medical director, and I think you use the word him, so I assume this is a male at this point in Omaha. Is that yes?
Yes.
All right. So when you're talking about contacting medical personnel, you aren't out on a scene and contacting that medical director, are you?
I'm sorry, could you repeat the question?
It wasn't a very good question. When you're out on a call and needing to talk to a doctor, you don't contact that medical director, do you?
No, we do.
Okay.
And our medical director is affiliated with Nebraska Medicine. So anytime we have medical control questions, we have both a phone number that we can call, and we can try and contact them over the radio as well.
Okay. And when you're on a call, is it also true that as you're getting information, you're feeding information into the hospital, whichever emergency room you're headed to? Is that fair to say?
Yes.
Okay. Are you ever talking to those docs about, hey, what might we do next?
Very rarely, because we have a pretty good, they call them standing orders. We have a pretty good set of standing orders as far as our protocol is concerned.
Okay. So the upshot of it is, am I saying it correctly, that you're not going to do some procedure that you're not trained to do, authorized to do, unless the medical director is telling you, do this?
Correct.
Okay. Would that be a pretty rare thing, that you're being directed to do something?
Yes. In my memory, I cannot think of anything throughout my paramedic career that I had to call medical control for permission to do XYZ procedure.
Okay. So what are the kind of things you can do?
I'm sorry?
What are the kind of things you can do as a paramedic without doctor authorization?
I don't know how extensive you want to be.
Just kind of
we can
general.
administer medications. We can start IVs. If somebody needs to be shocked, we can do that. That's kind of the basic extent.
Let me ask you this, because since we're talking about the episiotomy, I know because we're going to get to the exhibit in a minute that your OB kit, you do have a very small scalpel in there. So are there, and I guess do you have a scalpel on your rig other than in the OB kit?
We might, but no, I think it's only in the OB kit.
So are there sort of procedures you can do using a scalpel?
Not.
I suspect that the only thing that would be a perimortem cesarean section, and I think in that situation they would actually usually be instructed to start CPR and get to an emergency room to have that done by somebody who has a little bit more training in it.
Not that I'm aware of.
Okay, but you have that scalpel in the OB kit?
Correct.
Okay, so fair to say you don't exactly know why the scalpel's in there?
No, I do know why it's in there, and we've never, throughout my career, because I talked to the supply person, sometimes it's a specific type of scissors that might be in an OB kit, but throughout my career, it's always been a scalpel.
Okay, so why is the scalpel in there?
So that we can cut the umbilical cord.
Okay.
If we need to.
Oh, I see what you're saying. So there's some time, or you would expect also there might be
C-section in the field would happen only if there was a patient who was not alive, and I would suspect that they would also need to get to an emergency department first, because it sounds like they don't have any training on that, which, yeah, makes sense. But perimortem cesarean is basically if you have somebody who has coded, their heart has stopped, and they are pregnant, then they're flatlined, so you're trying to do life-saving measures to keep that person alive. No matter what the gestational age of the baby is that they're carrying, it is going to be putting them at a increased risk of being unable to achieve resuscitation, because there's blood flow being diverted there, and when somebody is dead or dying, they need all of the blood flow they can to their brain. So for a twofold reason, number one, you have about 5 minutes after the heart stops that you could get a baby out before it's also not alive. And two, getting the baby out increases the chances that you can restore circulation and cardiac activity to the person who has coded.
a scissors different than a trauma shears in the OB kit to cut the umbilical cord.
Correct.
Okay.
That's
All right.
basically C-section on
Okay,
somebody
I
who's
want
not
to
alive,
take
but
you
he's
to-
talking about we have the scalpel there to cut the umbilical cord.
Do what we're here to testify for, and that's June 15th, 2019. Do you recall that date?
I do.
Okay. And did you were you dispatched to 4826 Spalding Street?
I mean, I'd have to look in our daybook, but yes, I was on that run.
Okay. Who was with you that day?
I'm sorry.
Who was with you that day?
On the medic unit, it was Dave Hurd,
Okay. What do you mean by medic unit?
the ambulance,
Okay. Who else was heading to the call?
engine 41,
Okay. So how many people were on the engine 41?
4.
So 4 ride in the engine, 2 ride in the medic unit.
Yes.
What information did you have initially about what kind of call you were going to?
The way dispatch works is they call it toned out at the station, and the first thing that comes over the dispatch is the apparatuses that are going. So it was engine 41, medic 41, maternity issues, and then they give the address.
Okay.
And then we go en route.
So initially maternity issues was the extent of what you knew was happening.
Correct, because when dispatch dispatches us, it's very generic, I guess to say. So it could be chest pain, it could be what they call PI, car accident, difficulty breathing. They're not on the initial dispatch going to give you any extra information other than the general dispatch.
While en route, did you get more information?
Yes, and that's standard. So once we were en route, they said, I don't remember the age, but it was a 20-something-year-old, is in the birthing process, and the feet have been delivered.
What did you think when you learned that the feet had been delivered?
I knew it was going to be a serious call. I asked Dave, because Dave had much more experience at the time than I did, if he'd ever had a breech delivery. He said he had not. And the way we do things on the fire department is when you're on the medic unit, you take turns, quote unquote, being in charge of that call. So it was going to be Dave's patient. And so I told him, you go and do whatever you can to assist in the delivery. And I will grab the OB kit and I will grab the airway bag and I'll set all that up and have it ready to go. So
I know Dave Hurd retired at a rank of captain.
correct.
What is your rank?
Firefighter.
Okay. So it doesn't matter that Dave Hurd is captain. Literally, you're taking turns as far as who's in charge. That captain isn't necessarily running the show every time. Is that fair to say?
Correct.
Okay. All right. So what is this OB kit used for?
For when we go on calls where a baby's been delivered.
Okay. I'm going to show you what's been marked. Exhibit number 130. Do you recognize this?
Yeah, I recognize it. That's kind of a standard OB kit for us.
And in fact, did you supply this, or somebody at the fire department supply this to my office for use in this trial?
Yes.
So would this be a fair demonstrative exhibit of the kind of kit you were using on this date?
Correct. It may have been a different brand because the fire department, like anywhere else, tries to save money. So if they got XYZ brand and then they go up in price, then they'll try to negotiate and find a cheaper brand with the same materials in it.
And one of the things this kit has in it is this scalpel you talked about. Is that true?
Yes.
Okay. At this time, Your Honor, I'm offering exhibit 130 for demonstrative for my witness to talk about it.
No objection.
130 is received.
I want to look at this, and for the record, we have a plastic bag here, and it's got listed all the items that are inside here. Is that right?
Yes.
Why don't you just tell us what those items are?
An underpad, a bowl syringe, umbilical cord clamps, PVP prep pads, safety scalpel, OB napkins, baby receiving blanket, pair of gloves, OB towelette, plastic pre-cut twist ties, plastic bag, one towel, one gauze pad.
I'm going to try to show this to the court, and I think we can do this. You see me unwrapping what appears to be a lightweight blanket? Is that what this is?
Yes.
Okay.
It's actually a pad, but
Oh,
yes.
it's a pad, okay. I thought perhaps this was a blanket to wrap the baby, but that's not what that is.
Oh, I don't know. I can't see that far.
No, just this is considered a pad, the white thing.
Or a blanket.
Okay.
I'd have to look at the list.
Oh, okay. All right.
Because, to be honest with you, we do not use OB kits very often.
Okay, all right. And you have plenty of blankets probably in the ambulance. Is that true?
Yes.
Because it certainly might be that you would put the baby in a blanket when the baby's born, correct?
Correct.
Okay. So these are all these items, and I'm mostly interested in. Of course, we have gloves. Different. What are these? You see up on the screen. What are these?
I'm assuming the clamps.
Is it a better view if you look at it like that?
Yes.
Okay. All right. And then I'm interested, of course, in the scalpel. I'm showing you what's inside here. It looks like a blue little plastic thing that with a red thing on it that you could probably just push out the scalpel. Is that fair to say?
Yes.
Okay. And this, of course, is sterile. It's inside a sterile paper. Is that
Yes.
right? And these, of course, are just all the other things that you described listed on this kit. True?
Yes.
One moment, cousin.
Okay, I'm going to go through some of this. This is like the same thing over and over. Basically, why were you giving, not coming in with
How did
your
you
equipment?
feel
And
in those moments in the ambulance when this baby wasn't being born yet and was starting to turn blue?
Helpless.
You attempted to help Emily give birth to her child,
Yes.
and once the child was born, you testified that initially it had good color?
When it was born, no.
No. What type of mask did you attempt the resuscitation on the child?
No.
Do you remember who did that?
I know Dave was doing the chest compressions, and I don't know who was doing the ventilations.
What type of mask and do you carry that would have been used in this situation?
It's the initials, and what we normally refer to it as is called a BVM, and that stands for bag valve mask.
And you just have one type of mask?
No, we've got one for infants, we've got one for pediatrics, and we've got one for adults.
Do you have one specifically for neonates, for newborn infants?
We do, yes.
Is that the one that was used?
I do not recall.
Can you tell me what the normal respiration rate for a neonate is?
Gallo glasses, when did they get the baby out? Sometime on the way to the hospital, they were able to have her push again with her legs repositioned and the baby was delivered. It's not uncommon that when things like this happen, when you start moving a patient around, that adjusts things just enough to eventually get the outcome that you were hoping for much earlier.
40 to 60.
How does that differ from a child?
A child's going to be 30 to 40. Well, it depends on the age of the child.
Would you agree with me that when you arrived, it was your hope that that baby would be delivered as soon as possible?
Yes.
And you agree with me that everything you did was for the purpose of delivering that baby?
Yes.
Was the bot, when you arrived, was the bot brought immediately up?
No.
Someone had to go get that bot?
Yes.
How fast can you transfer, all things being equal, how fast can you load and transport a patient or get them into the ambulance from the scene?
It depends on the situation.
Are you trained to do that quickly?
Again, it depends on the situation.
In a situation like this, the physical act of loading Emily No onto the bot and taking her to the ambulance, how long did that take?
I do not recall the exact time frame, but it's going to probably be 2 to 3 minutes.
May I approach?
You may.
Your Honor, I'm handing you a patient care report. Do you recognize that?
Yes.
Is that the report that you signed off on after this incident?
Indirectly, I signed off on it, but it was not I am not the one that filled out the patient care report.
Is your signature, is one of these your signature?
Mm-mm.
Whose signatures are those?
This one looks like Dave Hurd. Oh, I'm assuming that's probably somebody from the hospital.
Okay. Well, you contributed to this report being made.
Correct. My name's on the front page.
I'd like to offer this report as Defense Exhibit 132.
Objection, hearsay.
It's not clear how long baby was stuck, like delivered. It was a long time that it sounds like there was a delay in calling, but I haven't really been able to line out what the time frame actually was. Hello, Ella the Bunny Mom. Thank you, 4-month subscriber. I think that's like the entirety of the time that I've been on Twitch, so happy you're here.
Firefighter, are you a mandatory reporter?
Yes.
Is your understanding that being a mandatory reporter requires you to report suspected child abuse to a law enforcement agent?
Yes.
Did you make a report to law enforcement agent in this case?
No.
Did you cause a report to be made in this case?
No.
Yeah, Attorney Manbun is real stuck on the big orange thing and all of the same questions for everybody. Like, weren't you supposed to report the child abuse that you witnessed of the fetus that was being born? I mean, I don't know. Is that really the role of an EMT basic to go like, this midwife is doing something crazy? They don't know that. They don't have the training. I don't know. I think it's silly to expect that of them. Not on your part asking the question. I just mean, like, if that's actually the problem, I would think that would be kind of silly. I'm not sure if it's because, I think it's because they had it muted because attorneys were meeting. Remember, our judge got mad at Court TV for not muting the attorneys earlier. What he's asking is, should you have been putting an intraosseous line? And that's goes into the inside of a bone, usually in one of the long bones of the leg, and allows for rapid resuscitation in somebody who you can't get an IV in, which a baby that had been in severe distress and hypoxia for a significant time frame would be not able to be easily get in access. Sorry, the sound was gone. They basically just asked why they didn't place an IO, and he said it's because the baby was born while we were there.
No further questions.
It stands for intraosseous,
What does that mean?
where you're putting a needle into a bone.
You talked about not using the suction to the mouth and nose, and that you did not do that. Why did you not do that?
Because we did not have any access.
I'm talking about after the child is born.
Again, because we were already on it. The delivery happened as we were backing into the ER.
Okay. So you were getting Vera and her mom Emily to the hospital staff as soon as you could.
Yes.
Okay. I know you don't have any episiotomy experience. We had a number of questions about these sharp scissors, blunt stickers, scissors, and scalpel. If you were wanting to cut through tissue, skin, and muscle, knowing what you know about the trauma shears and the scalpel, which one would you want to use to be able to effectively cut through muscle?
Again, like you stated, I have no idea how an episiotomy works, but I would assume if you are cutting through skin, like you see on TV when they're doing surgeries, they use a scalpel to cut through skin.
So it's just your logic thinking that if you're going to cut through something, you need something sharper than trauma shears. Is that fair to say?
Yes.
Okay. There are some questions about being a mandatory reporter. When you were at the scene, did you have information about how much time had passed between knowledge of the breech presentation versus calling 911?
Did not, no.
So when this whole thing was over, did you have concerns about what might have gone wrong during this delivery at that home?
Yes.
Okay. And what was your concern a child abuse concern or a practicing medicine without a license concern?
I don't think either, because I did not know until after the fact what had transpired.
Okay. So well after the fact, after you've already turned the two patients over to the hospital, and so at that point the hospital was involved, that's when you started to get information fed to you about what might have transpired at the house?
Yes.
Okay. I have no further questions.
Thanks, sir. Can we sit down? You're done? Take your water with you, please. Thanks. I always forget.
You're on the second channel. Make sure you subscribe. If you're subscribed to my main channel, you might not be subscribed to MJJ Clips, so make sure you're subscribed down below so you don't miss out on any of the fun.